Chest pain is not always a heart attack, but it should never be ignored. Chest pain can come from many places in the body: the heart, lungs, esophagus, muscles, even the mind, and most of those causes are not a heart attack. But here's the reality: patients and clinicians must understand. The body doesn't label pain by urgency. A mild ache can hide a life-threatening condition, and a severe stabbing pain can turn out to be something benign. One of the biggest challenges in emergency medicine is differentiating between life-threatening chest pain and less dangerous causes. And that challenge is real because the body doesn't present symptoms in neat categories. Two patients can look completely different, yet one is having an MI and the other is having reflux, or the reverse. Here are some important clinical clues everyone should know. Possible heart attack, cardiac pain. When we talk about chest pain, the first thing we have to rule out is a possible heart attack. Cardiac pain has some very specific red flags. Clinical clues everyone should know. Pressure, squeezing, heaviness or tightness in the center of the chest. Pain spreading to the arm, jaw, neck, shoulder, or back. Associated sweating, nausea, dizziness, or shortness of breath. Often lasts 15 minutes. May occur at rest. This is a medical emergency. Seek immediate care right away. Chest pain that might be cardiac is treated as an emergency because the risk of doing nothing is catastrophic, and the benefit of early care is life-saving. Angina. It is chest discomfort caused by reduced blood flow to the heart, usually from narrowed coronary arteries. It is not a heart attack, but it is a warning sign that the heart is under stress. Clinical clues to find a person with angina may include similar pressure-like chest discomfort. Angina often feels like the same type of pressure, tightness, or heaviness seen in cardiac pain, but usually milder and more predictable. Usually triggered by exertion or stress. Walking uphill, climbing stairs, rushing, cold weather, or emotional stress can bring it on because the heart needs more oxygen than the narrowed arteries can deliver. And usually improves with rest within minutes. When the heart's workload decreases, blood flow improves, and the discomfort typically fades quickly. If symptoms become unpredictable or occur at rest, it may indicate unstable angina, an emergency condition. Because when angina stops behaving like stable, predictable angina and starts showing up at rest or in new, unpredictable ways, it signals that the heart may not be getting enough blood even during minimal activity. That shift can mean the coronary arteries are becoming dangerously narrowed or unstable. That's why it's treated as an emergency condition and needs immediate medical evaluation. Acid reflux, GERD, gastroesophageal reflux disease, happens when stomach acid flows back into the esophagus, causing irritation and a burning sensation. It's not related to the heart, but it can mimic chest pain, which is why it often gets confused with cardiac causes. Clinical clues includes burning sensation behind the breastbone, often described as a burning or hot feeling rising from the upper stomach into the chest. Sour taste or worsening after meals, lying down. Symptoms commonly flare after eating, bending over, or lying flat because stomach acid moves upward into the esophagus. Also, it's often confused with cardiac pain. GERD can mimic chest pressure or discomfort, which is why it's part of the chest pain differential, but it is not related to the heart. Symptoms of acid. Reflux or GERD may occur when after eating, especially large or spicy meals. When lying down or bending over because stomach acid moves upward more easily. At night when gravity no longer helps keep acid in the stomach. During periods of stress which can increase acid production. With certain triggers like caffeine, alcohol, chocolate, citrus, or fatty foods. These patterns help distinguish GERD from cardiac causes, but because reflux can mimic chest pain, any new, severe, or uncertain symptoms should be evaluated by a healthcare professional to rule out more serious conditions. Next would be musculoskeletal chest pain. Musculoskeletal chest pain is chest pain that comes from the muscles, bones, joints, or connective tissues of the chest wall, not from the heart or lungs. It is one of the most common causes of chest pain seen in clinics and emergency departments, and it is usually benign, though it can feel alarming. Musculoskeletal chest pain comes from the chest wall, the ribs, intercostal muscles, cartilage, ligaments, or thoracic spine. It is considered non-cardiac chest pain, meaning it does not come from the heart. Musculoskeletal chest pain is more likely to be reproducible with touch or movement. When pressing on the chest wall or moving the torso recreates the pain, It strongly indicates the source is the muscles, bones, or joints of the chest, not the heart or lungs. Worse with certain movements or coughing because the pain originates from the chest wall structures, muscles, ribs, joints, or cartilage. When these tissues stretch or contract, the inflamed or strained area is triggered. Common in costochondritis or muscle strain. Both costochondritis and muscle strain involve inflamed or irritated chest wall structures. Next is pleuritic, lung-related pain. Pleuritic pain arises when the pleura, the thin membranes lining the lungs and chest cavity, become inflamed or irritated. Each breath causes these surfaces to rub together, producing a sharp, stabbing pain that worsens with deep inspiration, coughing, or sneezing. Unlike cardiac pain, pleuritic pain is localized, often felt along one side of the chest, and may change with posture or breathing effort. Clinical clues everyone should know. Sharp, stabbing pain that worsens with deep breathing or coughing. This pain occurs when the pleura, the thin membranes surrounding the lungs and lining the chest cavity, become inflamed or irritated. Each time a person inhales deeply or coughs, the inflamed pleural surfaces rub against each other, producing a sharp, stabbing sensation. Because the pleura are richly supplied with pain fibers, even small areas of inflammation can cause intense discomfort. When patients say their pain catches with each breath, they're describing a sudden, sharp jolt that interrupts inhalation. This happens because the pleura, the thin membranes covering the lungs and chest wall, are inflamed. And also, pain arises from inflamed pleural surfaces rubbing together during respiration. This mechanism explains why pleuritic pain is respiration-dependent. It worsens when the pleural surfaces move. If accompanied by breathlessness or hypoxia, it may indicate serious conditions such as pulmonary embolism or pneumothorax, requiring urgent evaluation. Red flags that needs to go to the ER immediately. Chest pain combined with shortness of breath suggests the heart or lungs may be failing to deliver oxygen effectively. This combination is a major red flag because it often indicates life-threatening conditions rather than simple musculoskeletal pain, such as coronary artery causing a heart attack, or pulmonary emergencies like a blood clot in the lung, pulmonary embolism. Another red flag is fainting or collapse. Fainting or collapse is another critical red flag that demands immediate medical attention. When a person suddenly loses consciousness or collapses, it can indicate a serious drop in blood flow or oxygen delivery to the brain, often caused by underlying cardiac or respiratory emergencies. Sudden sweating plus chest pressure. Sudden, unexplained sweating accompanied by chest pressure or heaviness often signals acute cardiac ischemia, the heart struggling to pump due to blocked blood flow. Another red flag is pain radiating to jaw, left arm. Chest pain that spreads to the jaw, neck, shoulder, or left arm often indicates cardiac ischemia, the heart muscle not getting enough oxygen. Also, a red flag is severe chest pain lasting more than a few minutes. Persistent, crushing, or heavy chest pain that doesn't ease with rest or lasts longer than a few minutes often signals acute myocardial infarction. The heart muscle is being deprived of oxygen. This symptom demands immediate emergency action. And also, red flags include for new chest pain in diabetics, elderly patients, or women. Symptoms may be atypical. New chest pain in diabetics, elderly patients, or women often presents atypically, which means the classic crushing pressure may be absent. These patients might describe vague symptoms like fatigue, nausea, shortness of breath, or back pain, and those subtleties can delay recognition of a heart attack. The key lesson is that chest pain should never be self-diagnosed. Early recognition saves lives. Even experienced clinicians emphasize that only a proper medical evaluation can rule out life-threatening causes. The danger lies in assuming it's just stress or acid reflux. Every minute of delay can mean more heart muscle damage, or the difference between survival and loss.